Hello and welcome everyone to this evening's Thermographic Diagnostic Imaging / Health Through Awareness webinar series. My name is Leisha Getson and I'm a board certified thermography technician with Thermographic Diagnostic Imaging and the creator of the Health Through Awareness series, a venture to bring like-minded individuals together to share experience and expertise on a wide variety of holistic health topics via our monthly newsletters and webinars. Before we begin, just a little housekeeping. This presentation will be about 50 minutes, followed by Q&A. You should be able to hear me and the speaker as well as follow the PowerPoint presentation. To the right of your screen, you'll see a little chat box. So if you have a question, just please type it in and submit it, and we'll get to as many questions as possible. If for some reason you get cut off, you can try to sign back in and catch up. But if you can't, don't worry. This webinar will be archived along with the PowerPoint presentation and available on our website and YouTube. And we will make that link available to you in the next day or two. So without further ado, let me introduce our speaker for this evening. Tonight we have Mark Butler, a board-certified orthopedic clinical specialist and McKenzie certified specialist for mechanical diagnosis and treatment. He will be discussing graded motor imagery for the treatment of complex regional pain syndrome and other chronic pain conditions. Mark has taught over 200 weekend courses on neural mobilization, instrument-assisted soft tissue mobilization, examination and treatment of the shoulder, cervical spine, lumbar spine, therapeutic taping, and radiology. He's presented at more than 25 national and regional conferences on neural mobilization, brachial plexopathies, the shoulder, and complex regional pain syndrome. Mark is also fortunate to be honored to receive the prestigious James Tucker Excellent in Clinical Practice and Teaching Award by the New Jersey chapter of the American Physical Therapy Association. Currently, he manages the Medford NovaCare office where he carries a full caseload. And in addition to that, Dr. Getson had some words that he asked me to say about you, Mark. So I'm going to go ahead and do that. Dr. Getson says, Mark is the head of physical therapy at NovaCare in Medford. In my professional opinion, as a clinician for over 30 years, he is simply the best physical therapist I've ever encountered. He has a vast knowledge of different therapy techniques, is constantly learning new ways and changing his approaches as innovations become available. As an expert in chronic pain and especially complex regional pain syndrome, I make every effort to have my patients see Mark whenever possible, for I know that I can have a dialogue with him, that we will always collaborate for the best interests of the individual and most often for the best possible outcomes. Apart from all that, he is a really nice guy, which certainly helps when one is in pain and trying to rehab. Finally, when I personally wanted a PT program, I went to Mark for myself. I can offer no better recommendation. So there you go, Mark.
Oh, thank you.
Yes.
That's very, very nice to hear.
I think very, very highly of you, and the work that you do is, just fantastic. We hear it from patients over and over and over again. So we're very excited to appreciate
those words.
Yeah, we're very excited to see what you have to bring with tonight. And also, just as a note, folks, if you want to get a pen and paper, Mark is going to be taking us through a voluntary quiz, which will give you an idea of how this works in the physical therapy office setting. Okay.
Well, very good. Again, thank you for asking me to take part in this webinar. I'm honored. This is a newer experience for me. I've done this type of over the web type lecturing only a few times, so I'm just getting started in this area. But when you approached me and asked me to put together a topic that I thought was very relevant, I chose, of course, dealing with chronic pain.
Mm-hmm.
And some of the changes that have been the direct result of fairly recent, in the past 10 years or so, with even more information coming to light on a regular basis as to what is pain, how to treat it, how to work with it, and a bit of a paradigm shift in what we're doing in the clinic. So I'm going to narrow it down a bit. I'm going to talk about the concept of graded motor imagery. That's a bit of a, can be a bit confusing, but as I work through the topic, it should be relatively pretty straightforward to help you understand this process.
Okay.
And again, this works on many levels of pain. It's not for the only the very severe cases, but we found it is very effective in helping with that. So we'll jump right into the meat of the presentation by just talking about the conventional wisdom as to how we would deal with patients that came to see us with pain. We would tend to think from the body up. If you had a foot pain or a knee pain or a hip pain or an arm pain or a pain showing up in your back or whatever, we would go to that region and we would examine it and we would work on it, and in many cases could make a significant change. But there are patients that it doesn't seem to matter what we do, the pain still remains and is prevalent. And medical science has taken this idea of looking for pain to find an anatomical or a tissue specific problem. Something's torn, something's damaged, and that damaged area either needs to go through a healing process or the surgeon has to intervene by trying to repair that damaged tissue, or the anesthesiologist or pain specialist will put a needle into the area to try and block the pain. But quite often, again, these interventions can be very frustrating and often fail. And learning more about pain and realizing that it's not always from the brain or from the tissue in the body, we've taken a more of a contemporary evidence-based process in understanding the process of pain. And this is kind of where we're going from our rehabilitation side, is instead of with these patients thinking body up, or from the brain down. So when we look inside these patients' process of how they interact with society and their world, we're finding that there are some differences, and those differences are from the brain down. So if we're going to make a difference or treat them, this needs to be our primary starting point. So I'm going to talk a little bit about getting into a little bit of nuts and bolts here and talk about the brain in a simplistic way, but hopefully give you an understanding of why we've kind of come to this decision. Okay. So we're going to start with a word that I learned when I was back going to school in physical therapy school, and that word is the homunculus. I never really knew exactly what the word was. I knew it was a representation of a map of a part of our brain, but any of you that have watched TV and happen to have seen The Big Bang Theory, a comedy that's on regularly, I actually learned what the homunculus means. It means little tiny man. All right. So we have a little tiny man mapped out on our brain, or if you're a woman, I guess it would be a little tiny woman. All right. So what you have here, if we look at this image here, and I'm going to move my cursor over, so I hope you can see that moving along the screen. Yep. So this strip along the brain that they've highlighted by coloring in, this is an example of what we call the somatosensory cortex. Somato means brain or body, and sensory, of course, is what your sensations or feelings are. Cortex is actually the outermost layer of the brain. So in the somatosensory cortex, if we expand this brown strip here and draw it out, each of these colored regions actually represent nerves that the brain has set aside to process information coming from different parts of the body. And if we take these little squares and actually draw an individual to scale of what the brain looks at from it processes information, we'll see the body is represented in a very unusual fashion. Where we get the most sensation is where the larger part. So you can see here the hand is very large. Mm-hmm. The lips and tongue are very, very large. A lot of sensory organs in the lips and tongue, and then in the genitals and as well as the feet. So if I were to, in the middle of a brain surgical procedure, push on these areas or tap on them during a surgical procedure, the patient actually feels sensation in the corresponding area of their body. Pretty fascinating area, but that's interesting. Yeah, that's how that is how they began to draw these maps. So pretty fascinating stuff.
Can I ask you a question regarding this little map here? Mm-hmm. Is it? I I had a friend whose mother had, and this may be off, not in track, but I had a friend whose mother had a tumor in her brain, and it actually was sitting in an area where it kind of knocked out her worry impulse. Is
Yeah.
there a place on the brain? I've often asked Philip, is there a place on the brain where if you worked on that area, you could kind of take that worry impulse out?
Well, they've actually mapped out more sophisticated than some of those older maps you would see where they would have drawings on the brain and emotions written here and there. But we know that all the surface areas of the brain, especially the cerebral cortex area, process. We have an area that processes emotions, an area that processes your ability to thought and reason. And if you have a trauma or injury to the area, say, that processes the emotional component of worry, you'd worry less. You'd probably take more risks. So that's definitely, and that actually ties into what I'm going to talk about later, because when we start talking about pain, it gets pretty complex because your emotions actually link into the pain process as well. So yeah, the question is very appropriate. And yes, there are areas of the brain that map specifically to emotions, memories, smells, etc. And those are stored in those areas, definitely.
Okay, great. Interesting.
So, all right, so that's the somatosensory cortex. And if we take a look at the cortex right next to it, again, the blue in this case is representing somatosensory, or what we feel. The dark brownish reddish strip here is called your motor cortex. And again, we've simplified it down, but you see they kind of lie along each other, and they have very similar mirroring of areas where your sensory components are also very much represented heavily with neurons that are specifically designed to move that area or coordinate movement or initiate movement. We actually call it there's a premotor cortex, and when you think about movement, you actually prepare neurons that actually turn on to make the muscles move. So every process, every movement is a multiple step process to get these to fire. So you've got a sensory component strip right alongside a actual strip of neurons which help and guide movement. All right.
Okay. Yeah.
Okay. So now let's do a scenario. I'm going to show you a picture here. This is just a typical pothole. Let's put this pothole in the middle of a road in Spain. All right. You're on vacation in beautiful sunny Spain. You're walking down the road. It's a nice, calm, quiet, say maybe middle of the weekday. Everybody's at work. You have pretty much the area to yourself. You're looking up and you're enjoying the architecture. You're not really paying attention to what the road is in front of you. And you inadvertently step into this pothole. Cool. That would set off a whole sequence of events. You would feel a flash of signals coming from your foot and ankle up to your brain. Your brain would take that information and assign meaning to it. You would most likely have blinding pain. You would immediately crumple to the ground. You'd probably sit on the ground for maybe a number of minutes, if not longer, and maybe have someone help you hobble off to the edge of the street and sit there, and your ankle would throb, and it'd be a painful experience. Now, we're going to do another scenario. You're on the same street in Spain, maybe the following weekend, but you happen to be there in the middle of the running of the bulls. Right? So here you are. You're one of these individuals dressed in white. That bull's coming up on you, and you're not looking ahead. You're looking back, and that same pothole is there. You step in the pothole, sprain your ankle, and look back, and that's what you see. Would you experience pain? The answer is probably not. Your body would recognize that you're in imminent danger, and therefore you would not feel pain. You would get up, run off to the edge of the road, and maybe once the whole process had passed and your adrenaline had calmed a bit and your heart stopped beating, then your body might say, hey, something happened to me. I stepped in that pothole and I've got a problem. All right. So the question that I want to put to,
if you have a slide up right now, but after the bull, it went blank.
It went black. Yep. I'm going to give
okay,
quiz.
gotcha. Oh, okay, gotcha. All right.
Right. So this is a true or false quiz. I have nerves that send pain signals to my brain. And, so Alicia, I'm going to put that question to you. What do you think? Do you think you have nerves that send pain signals to your brain?
I think
and that is that's a general thought process, that you do have nerves that send pain signals, but the answer is false, actually.
Okay.
You have nerves that send signals when the tissue has been damaged, but the brain decides whether or not to assign pain to that message.
Really?
All right.
Wow.
And the nerves that send signals to your brain that your brain can decide whether it is a painful experience or not are closely related to the same nerves. In fact, they're almost identical. It would be hard to tell the difference of nerves that tell you if you're moving your foot up and down, or if there's mechanical stress on the body, someone pushing on you or tickling you. The same nerves that would send response in that are also very similar and very commonly associated with nerves that can send signals that your brain associates as pain. All right.
Okay.
So what is pain, and how does it happen? It's been something that has really been a bit of a long-standing research, and we've come to learn that pain is a couple of things. All right. Now I've got two statements here that are a bit confusing, and I'm not going to really delve into all the meaning behind them. But the first one, the unimodal nociceptors. The word nociceptor is the type of nerve that is the nerve that sends a signal that your brain has to decide whether that signal is important enough to assign pain to it or not. Nociceptors are related to mechanoreceptors. Nociceptors are more oriented towards sending a signal of danger or damage, typically. But again, they're not always going to send that type of signal. So what the unimodals do is they send a brief, quick flash of information. The brain takes that information and decides to act on it or not. Let's go back to the first scenario where you sprain your ankle where you're in no danger.
Mm-hmm.
Your brain knows you're not in danger. It can immediately address what happened, and it will assign pain to it for a reason. It assigns pain to it, that episode you turn your ankle, to say, next time you're walking down the street, you better not be looking up all the time. You better pay attention to what's in front of you.
Mm-hmm.
So it creates a behavioral change. That's what pain is about, is to help you learn. And you learn from a very young age that pain means stop doing what you're doing and do something differently. All right?
Right.
Then you have another type of nociceptor called a polymodal nociceptor. These are a little bit less rapidly adapting. They're reactive to the chemical environment which is around them, specifically inflammation. Inflammation is both a neurological and a chemical process where the tissue becomes bathed with chemicals that are released when the tissue becomes damaged. And that inflammation soup of chemicals keeps these nerves on that constant state of irritation or achiness. And that would be that ankle, once you got off to the edge of the road and the episode of the injury was past, but you continue to feel the foot swelling, the achiness, you would hobble on it. And this is a signal to say, hey, something's injured here. You better stay off of it and protect it. So this creates a lingering pain experience to keep you safe and to change your behavior so you do not continue to injure the tissue once it's been injured.
Mm-hmm.
Now this is an oversimplification, but it's a pretty good representation of how pain is. Pain is an emotion. It's a feeling. It's an experience that the brain assigns to information coming from the body. Your brain has the ability to ignore or to assign meaning to it. And another example of this would be somebody who is in a very severe accident, possibly loses a limb, or in battle. Very often they'll report they're not even aware they've lost the limb or how severe their injury is until they have a chance to look down and assess it. You have an office worker who, reaching into a sheaf of papers, gets a nasty paper cut, and they'll probably experience more pain in that episode than the person who loses a limb or severe injury. It's all because of the brain's the way the brain assigns meaning and the ability it has to pay attention, or the amount of distraction around, or the amount of danger you're in, and if it has to or can assign meaning to that experience. All right.
That's really interesting.
Pain is a fluid subject, but there's a lot of people out there that say, I'm in pain and I'm in pain all the time. And this description of acute pain does not in any way, shape, or form match what their experience is. So again, pain's major role in the acute phase is to protect and limit damage. Protect from damage and limit further damage. Pain, it's a whole different animal. Chronic pain is again a brain's response to something. So what happens when you have a chronic pain situation going on is nociception, or the signals that the brain would normally perceive as painful, is actually enhanced. So things that are a little bit painful become more painful. It also looks at normal sensory information, mechanical stimuli, a gentle push on the skin, or a light push, or a movement of an extremity. And instead of getting mechanical input, the brain perceives that as painful input. And those mechanoreceptors act as nociceptors. And now normal movement, normal activities become painful. And the body has learned that when you're in pain, you stop moving or you change the way you move. And that locks you into a cycle of dysfunction because it hurts to move. And the fact that you're not moving, the tissue becomes less healthy and you get locked in this vicious cycle. All right?
Yeah.
The brain also, in a normal situation, has the ability to send signals down the nerve pathways which actually interrupt or block a painful signal. Your brain can actually shut down signals. Your brain produces chemicals that are many more times powerful than anything you can get from the pharmacy. And when the brain is doing its job, it actually can do a beautiful job of blocking signals that would be perceived as painful. When you have a chronic pain situation going on, the brain loses its ability to block signals, and pain is actually fast-tracked. The pathways that facilitate pain within the brain are heightened and heavily awakened, and therefore things are, pain is a big part of your life, basically.
It sort of creates new neural pathways.
It sure does. Your brain actually starts to change its architecture. So in this case, when you're feeling pain, it has absolutely no value. It has no value whatsoever. If we can get our patients that are in this type of a situation to learn to interrupt that pain or assign less value to it, they tend to do better. We also have found that if patients understand this intimately and study this process, their pain levels actually diminish by, on an average, 2 to 3 levels on a pain scale of 0 to 10, just by understanding this process.
I'm not sure I understand the chronic pain has no value. You mean the brain is not putting a value on it?
No, it actually has no value to you in your life. The brain thinks it's value. It has no value whatsoever.
Okay.
It doesn't protect you from anything. It doesn't make your life any better. It doesn't keep you safe.
Okay.
It basically actually makes you more disabled and dysfunctional. It has no value whatsoever. So we spend billions of dollars looking for ways to interrupt pain. And so pain probably has more value to the physicians and the clinicians because they make a lot of money off of pain. But from your standpoint, or from the patient standpoint, it has really no value to make your life any safer or better. All right.
Okay.
So this is actually an image taken from one of my intake forms of a patient that came in to see me, of a drawing of their pain. Obviously, if we were to take this as this patient was in acute pain, this would be someone who maybe had been in a burn or in a fire and got burned all their whole body. But no, this is a patient who started with an injury, and that injury spread to the point where now they have pain all throughout their body. So we know that this tissue that the patient's drawn here is not damaged. The nervous system is now the culprit, and it's gone awry. All right?
Wow.
So they've actually done studies on patients that are in pain. And we're going to talk about a type of patient, which I'm sure many of the listeners are fully aware of, the complex regional pain syndromes, or the reflex sympathetic dystrophies. They have many names. But what we're talking about here is these patients where their nervous system has actually become the culprit in producing the painful experience. And these are actually images of a brain And at the top, you see fMRI during wrist extension. So what they've done is they've actually taken patients, they put them into a special MRI, and they've the functional MRI is actually pretty fascinating because they've been able to detect how your brain uses blood. This is oxygenated hemoglobin is what it's picking up. So the hemoglobin in the blood, the iron that holds on to the oxygen, when they set the MRI to pick up which portions have blood that is feeding the brain tissue, they can get an almost instant snapshot of what parts of the brain are active during activities, including even thinking about activities. So what you have here is a representation of the left hand and the right hand, not the brain, but what's going on when they either think about or move the left hand or the right hand. So we have a CRPS patient and a control patient. The CRPS patient is in this line here, and the control patient would be about left hand. This is actually the patient imagining moving their wrist so that the palm is bending down toward the floor or lifting up toward the ceiling. So we're moving the hand in the direction of the palm lifting away or flexing. I'm sorry, we're extending the wrist. Let me correct that. So you're lifting the hand up backwards. If your hand was on the table, palm down, you're extending the wrist or lifting the hand away from the table. So thinking about that, you can see the premotor cortex light up. You can see some of the other higher centers light up to assist in this process. Some of the memory centers for helping you remember how to move your wrist or thinking about something when you do that. In the CRPS patient, the brain scatters and lights up irregularly. All right. And on the right hand moving, again, you can see during the imagining phase, the right hand's probably this person's right hand dominant. So you can see a lot more normal activity on the right hand moving. And the CRPS brain, on thinking about it, it can't even think about moving the arm. So we'll see this in the clinic. We'll ask a patient to move that has a chronic pain state, and they have a hard time moving sometimes. All right. This is actually the patient executing the activity. Here we see the motor cortex light up, with again some of the higher centers light up with it. Our CRPS patient, we call this smudging. This organized strip of activity is actually spread out and mixed in with even into the sensory areas. So quite often the patient even thinking about the movement, pain. Because now we have the movement neurons linking with pain neurons and other things happening. So the brains of people that are in chronic pain actually behave differently and become wired differently than those that are not in chronic pain. And they don't have to have complex regional pain syndromes. We've seen this in patients who just have chronic back pain or chronic shoulder pain that's been there for quite a while. Their brain starts to reorganize and change the way it behaves.
Wow, that's fascinating.
All right. So this is just an enhanced or larger view of the exact same thing. Again, you have the imagining across the bottom of the activity, and you have the execution of the activity across the top. You can see clearly that those brains look differently.
They sure do.
All right. So we're going to use a case study to show us an example of just how valuable these processes can be. And I'm sure this individual is actually watching or listening to the podcast now, and I want to thank her for volunteering. I presented this at one of the Philadelphia hand conferences, and so this information was taken from that presentation. So it's a case study. A very vivacious, active woman in her early 40s. She works as in a job where she's interacting with individuals and pets, which she loves. She's very good at what she does. I think she's assisting one of her coworkers, and she gets a bite on the elbow, which injured the nerve, the funny bone nerve, the ulnar nerve, back in August of 2013. She's sent to physical therapy. Seemed to give her much relief. So she goes through a surgical procedure where they release the ulnar nerve, and unfortunately, things did not really improve when the doctor went in and tried to free up some of that injury to the nerve. All right. And this is from her own images, how her hand and arm looked at the early stage of her injury. You can see this is a healthy arm. This is the injured arm or hand over here. She would have to wear a protective sleeve because even wind or someone lightly brushing the area would signal a pain response. If you remember when I talked about pain, where just mechanical stimulus, which is not dangerous, which is not noxious, becomes a noxious, terrible stimulus. So these patients suffer. The puffiness that you see, we feel is driven by the nerves, which also participate in sending stimuli back and forth, which is painful, potentially painful.
Mm-hmm.
Those nerves release chemicals which actually drive inflammatory processes, and it becomes chronic. And the tissue changes in the way it looks in these really challenging case scenarios. All right.
All right.
So she eventually was released from physical therapy, went into pain management. She started injections for treatment for her diagnosis of complex regional pain syndrome or reflex sympathetic dystrophy. This diagnosis was formally rendered in the fall of 2014. In a second round of physical therapy with some very gifted and very talented physical therapists at the end of 2014. And their focus was, again, trying to get that hand moving, that body up approach. With a little bit of the graded motor imagery we're talking here. The therapists were exposed to it, but again, in its early stages, therapists were kind of trying to struggle with how to actually do it properly. And I don't know if properly is the right word, but they were using the components of it, and they were doing a very good job, but they were still encountering some challenges.
Okay.
She was reaching a point where the system that was working with her was considering the fact that she might have reached the maximum benefit from treatment, and they were going to take her to a point where they were going to say, this is probably as good as you're going to get. And that was about 6 months after this second round of physical therapy. She was actually referred to me because, I'd had some experience with these types of patients. And this patient ended up in my clinic, and we were starting from square one, where she was unable to move her arm away from her side. Her hand was barely functional, and her pain levels were at the top of the pain scales. These are early images of her arm. You would see that underneath that pink protective sleeve, her skin would be mottled and discolored. This is, again, a reaction from the changes in the way the blood vessels react to chronic pain, and the instability of the tissue. Just very normal tissue would be nice and pink and fleshy colored. In this case, the extent of the pain and the effect of it had on her had actually changed the appearance of the extremity where she was suffering.
Wow.
All right. So where do we begin with this type of a patient? And that's when a patient like this would come into most clinicians' offices, it's a scary thing.
Yeah.
We know they're going to be challenging. We know that we're going to be dealing with a lot of frustration on the patient's part as well. We know that we're going to have to walk very carefully not to make their life worse as we try to get them moving and doing better. So we start with, and when we use the graded motor imagery processes that have come out through research, and we're still researching this, we're in the fairly early stages. There's a lot of trial and error as to what works, and this is kind of where the state of the art is right now. I'm going to overview that. So how do we start to test these patients? We actually test them to see if their brain has started to reorganize or start to smudge, like that brain you saw in the MRI, where the little spots of activity were not where they should be, and problematic. And the Neural Orthopedic Institute, they're out of Australia. Some very gifted clinicians, researchers, and such. They've actually devised some testing techniques where they've been able to pick up whether or not the brain is able to have this organization still. So what you have here is these are apps that I've downloaded on my smartphone, and this is for the shoulder. This is one for the hand. This is for the foot, the back. They have a knee app. I think they have a hip app, and what we can do is we can actually use these apps, and we can test the patient to see if their brain has started to reorganize or started to smudge. This was originally discovered with patients that have had strokes or had amputations. We found that the part of their brain that was assigned to that area had started to lose focus and spread through the whole brain. And we call this cortical reorganizational. So the cortex reorganizes, and the patient loses the ability to mentally rotate an image and determine if they're looking at a right or a left. So we use a test to see if that's what's going on. That's what I wanted you all to have a pen and paper, because I'm going to show you images of hands, and you'll have about 5 seconds to look at each image, and you're going to put an R and L. So you're going to number, I think there's, I did only 10 images if I'm not mistaken.
Okay.
We usually test with 20 of them, but I'm going to have you take a test with 10.
And we're going to have to tell if it's right or left?
Just right or left. And I'll show you an example of, not the hand, but I'll show you an example of what the images would look like if we were testing for the back, because we find chronic back patients can't recognize an image of a patient that's bent to the right or to the left. They have a hard time identifying which direction they're bending to. So again, that's the app as it shows up on the screen. So this is what the image will look like. You'll have it'll come up, and you'd have a right or a left button at the bottom. And if you were taking this on your smartphone, you would actually touch the right or the left. So if you can see here, this individual is side bent and rotated to a certain direction. And if you look at that and go, I'm not sure which one it is, or if you've noticed right away, a person that was having right-sided low back pain would have a harder time than a patient that was having left-sided low back pain that was chronic, of many months duration, would statistically have a harder time recognizing this person is bent and twisted to the right. We have really good evidence that shows this happens. All right.
Wow.
Here's an example from the shoulder group. What shoulder are we looking at here? Again, a person with a chronic left shoulder injury would have a harder time recognizing this is a left shoulder, and they might. And when we run this test on the patients and we go back and score them, we find that if you score less than 80% accurate, 5% accurate, then you are probably showing some cortical reorganization going on. Now, if you're challenged right and left anyway, we have to take that into account. Some people are naturally that way, but we find about a 70 to 75% correlation with patients that are in chronic pain will score lower on their involved side. All right. All right. So we're going to get ready for the test now. If you guys are ready, got your paper out in front of you, number 1 to 10. So this is the way you would move through the screens. Over here is the screen. I would click on quick test. It would take me to here. I could enter, if I wanted to track a history for a patient, I could actually enter that information in. You could put your current pain level. I can set how many seconds per image and how many images for the test. We typically do a 20 image test, and we typically give 5 seconds per image, and then it goes on to the next image. All right.
Okay.
So you're right. You've all been warned. If you're taking the test, we're going to rock and roll right now. Okay. So the first image, and I'm going to count to 5 in my mind, and go to the next image. All right. So now you'll have your answers, and at the very end of the presentation, I'm going to put up the answer key. So that'll keep you guys glued to the in order to find out how you did. You can score yourself if you want. All right. So that was the first thing that I would do when I would go to examine you if you came into my clinic. It's not that important to me if I push on you or I twist you around. That type of exam does little good to give me any information that I can use. Now, I would take measurements. I would see what your flexibility looked like, or your ability to walk or sit, but I wouldn't really try to go in there and provoke your symptoms, because that doesn't give me any good information, because I know the tissue that is painful or where the pain response is coming from is not an injured area. So getting an idea of how your brain is working is much more important for me. All right.
Yeah, makes sense.
So what we do then is we would actually go through a retraining process and see exactly what what we need to work on here. So if you came out of that initial phase and you were scored low on that, the first phase of graded motor imagery, and each phase lasts for 2 weeks minimum, is to be doing these activities 5 to 10 minutes out of every waking hour. So if you're awake from 7 in the morning until 10 o'clock at night, that means every hour from 7 in the morning till 10 o'clock at night, you are doing these exercises. We are literally trying to rewire your brain. All right. We've learned from experienced athletes, and this is an example of me. I have a GoPro camera on. I'm a big skier. I'm watching my daughter ski down a steep mogul run, but I'm also planning out that I'm making that run in my brain. I take a few minutes to pause. I make a number of turns in my head, and then when I head down the hill, to make those turns and do it in such a way that I've already run that hill. Now, high-level athletes use these same principles to actually enhance their performance. They'll run through their performance or their jump or whatever because they've already started to do this process, and they do it very, very well in order to create enhanced performance. I'm going to leave this slide up here for a second and just tell you about a very fascinating study where they took individuals and they measured the strength at which they could push their little finger out to the side. They used a device that measured how much force a person could push that way. So it's a very isolated exercise or test of some very small muscles in the hand. They took, once they measured a baseline on the whole group they studied, they broke them up into 3 groups. One group did nothing, didn't exercise, nothing at all. Another group was given a rubber band, type resistance band, and was told to exercise against resistance against the rubber band on a regular basis. They probably did it every day or every other day. And then the third group was taught the exercises, but told only to imagine doing the exercises for the same amount of repetitions, the same frequency, the same time frame. When they went back and measured these individuals 4 to 8 weeks later, I think it was 4 weeks later, if I recall, they found that the group that they didn't do, that was left to do nothing, no change. The group that actually did the exercises, a significant change. And the group that thought about it also increased in strength. So we know that the act of imagining, now don't take that to mean that you can sit there and do your imaginary workout and be in great shape, but it shows you that the power of using your brain and getting the neurons in your brain working. You can exercise your brain. All right.
But that could possibly help a little bit, right, Mark? I mean, if you kind of visualize your workout before you do it, yeah, couldn't hurt.
We use this as a mode to help our patients. Again, the first 2 weeks or so when you start a strengthening or exercise program, the muscle doesn't really go through any changes. Your nervous system actually becomes more efficient at getting the signals to the muscles. And that is how you start to improve strength early on. And you can do that, again, by imagery work. It's been proven. All right? So now, going back to the graded motor imagery phases, we actually have 4 defined phases. Some people write about 3, some people write 4, some people write 5, etc. But I'm going to strike out on the 4 phases that we use right now. Okay. So the first phase of work is called laterality. In this phase, your assignment would be to get magazines or images, and as you go through those images and magazines, you would write on the extremity an R or an L. And you do this for 5 to 10 minutes every waking hour for 2 weeks straight. And you have someone track your accuracy. All right, so that's the first phase. It's just recognizing right and left. All right, we want to organize your brain so it can start to recognize right and left. It starts to take those disparate spots and bring them a little bit closer to where they should be. All right. Okay. Phase 2, we have the patient sitting in front of a mirror with their involved extremity hiding behind the mirror, and they would look at pictures of extremities or hands in a position, and they would only imagine their hand doing the same thing. So you can see over here, the involved hand is quiet.
Mm-hmm.
They're looking at this, and they actually are seeing a reflection of their well hand, because this is hidden from them. The patient can't see the side of the mirror. They see two hands that are healthy,
Oh, wow.
imagining that
Yeah.
motion. They do this every hour of every day that they're awake in front of a mirror for 5 to 10
For
minutes.
5 to, can you go to the back to the slide before that?
See?
Maybe.
All right.
Okay, so they're seeing
That's
in
what
the
they're
mirror.
seeing. They're seeing a
Okay.
reflection of two healthy hands.
Mm-hmm. Okay.
But their other hand, this hand is hidden from their view. We put a cover over this. I just uncovered it so you could see that the
Right.
hand is not doing anything in that area. All
All
right.
right. Yeah.
Then we go to phase 3, which is unaffected hand movement. What the patient does here is they would put that image down, and they would mimic the position or pose of the image, but their uninvolved hand is quiet. All right. But what they see is their involved hand doing the activity, and their brain will actually feel it.
Oh, wow. That's
They start to feel
amazing.
the brain. So the brain now starts to change the wiring of the neurons in the cerebral cortex to actually wire, hopefully without pain. Now, if the patient was having pain in their hand when they did this, which happens, they have to go back to the prior phase. They go back to the phase that was not non-painful, and they go another 2 weeks in that phase again. We don't ever move into pain. We don't exercise into pain. We don't have the patients do anything that increases their pain.
Wow. Mm-hmm.
So again, in this phase, they're making the motion, but their involved hand is quiet. Phase 4, the affected hand now will mimic what the involved hand or what the other hand is doing. And the patient won't see their hand moving. They'll see a reflection of their well hand or their healthy hand, and their injured or involved hand will be doing these movements behind the mirror. All right?
Yeah.
All right. Now, that takes a number of weeks. That's about almost a 2-month process. Sometimes it takes longer because we have to back up.
Mm-hmm.
They're not better yet. Now we're going to, but their pain levels in many cases, we've had patients, we put them behind the mirror, their pain rapidly goes to 0 as their brain is fooled, and then their pain comes back. So your brain really quickly can respond to these, and it can be quite disconcerting. But once we've trained them down to where they're now moving their extremity with less pain, we take them away from the mirror, or we have them stay behind the mirror and do functional activities where they're moving their uninvolved hand. Let me back up here. They're moving their uninvolved hand and seeing their involved hand do things. And we would take them through the same process of starting to mimic these activities behind the mirror. All right?
Okay. All right.
Start with something very non-threatening and non-noxious and have them go through that process.
All right.
All right? And then we'd eventually take them from behind the mirror and start doing some other tricky things. We find that if we have patients cross the midline, that they do not have as much pain. So we're having my patient here, she's a dog groomer, so we put a stuffed dog with a weight around it, and she's crossing midline to lower her pain levels. All right?
What do you mean by that, Mark, crossing midline?
Across her body. Here, she's reaching across her body to actually make her involved arm reach across the half.
Oh, I see.
We find that interrupts pain when we do that with patients. It's a little trick, and we can do infinite variations of this. We start with non-threatening, non-painful motions. Now remember, when this patient started, she couldn't really move her arm away from her body.
Right.
And now we're starting to have her move in a pain-free environment or pain minimal environment to start to get some function back. She couldn't tolerate the vibration of the clippers. So what we did is we had her wrap the clippers up, and we actually started with the clippers on the ground and have her stand on them with her foot under a pad to start to get her body used to vibration.
Wow.
Vibration and cold tends to be two of the most challenging sensations for patients that are in this severe pain. But we were able to, again, slowly work towards from a non-threatening to a more functional type of activities. All right.
Okay.
And I can start to do some manual therapies. I can actually start to move them around where before I couldn't touch the extremity. look at the difference in the color of the extremity.
Wow.
It's
Yeah.
actually improving.
Mm.
All right. So
Mhm.
I can do some hands-on work. I can work on the tissue. I can mobilize the tissue. I'm using an instrument that is actually specially fashioned to mobilize the tissue and lift the tissue away along the nerve beds, where before I wouldn't be able to touch her because of the level of pain. I've
Wow.
lowered her pain. Now I can actually do some work with her. All right. Takes a lot of patience
So
and
you haven't
experience.
really done it's in a way, and I can't ever say this word, is desensitization.
Desensitization is a bit of a challenging process. We might save that for the very end when we've done everything and we've got them way away from that sense of danger, and we can use the desensitization techniques to fine tune. But if we use it too early on, it tends to make the patient more painful. And if we
Right.
do that, we just wire more pain into the process.
Okay. I'm just
All
so
right.
surprised you were able to use that instrument on her.
Oh,
That's
yeah.
pretty amazing.
Excellent
Yeah.
results. And
Yeah.
after using this, her movement dramatically improved, so much so that she could raise her arm above her head.
Wow.
Right.
Wow, that's
And this took
amazing.
months and months and months, and you can see she's pretty happy there.
Yes, she
All right.
is. There was a
Some of
question,
it worked
Mark.
very hard.
Yes, there's not to, I don't know if this is out of line, but Jen wants to know about the phase. How do you do this phase with patient having back pain?
Well, a patient with back pain would actually exercise in front of a mirror. They would have them do exercises and movements, which they see their body moving,
Okay.
and we couldn't hide them. We've actually used this on patients with facial pain. Um, a pretty wide variety of patients. So we find that if you're coming in my clinic, one whole wall is a mirror, and we have our patients exercise a lot in front of the mirror because their brain seeing their body move is a very powerful interrupter of pain and enhances movement. So a back or something like a hip where we can't hide it behind a mirror, we just let them see the whole thing and see the process
Okay.
unfold that way. All right.
Okay.
And
Thank you.
there are research articles that have shown that patients with back pain get better pain reduction and better results exercising in front of a mirror.
Okay.
Okay.
Good.
You can see here that this patient's arm is much more calm. Now, it can vary on days where she's having a little bit of a struggle. These will be a little bit more apparent, but you can see how much more cleaned up this tissue is and how less angry looking it is
Mm.
from all the work that she's been able to achieve. And I cannot overemphasize how hard and how diligent this patient worked.
Yeah.
The patients that don't do well, every patient that has never followed through with this task has not done well.
Mm-hmm.
So the reason we have failures here is more often than not, we don't know if that patient would have done well because they can't stick with the program. They give up because it's not happening fast enough.
It's not.
This
It's
patient
not
has
happening
been
fast enough. Okay.
absolutely amazing in how diligent and hard she has worked, and it has
Mm-hmm.
paid off. Right? Remember, they're ready to give up on her. She was never going to raise her arm away from her body,
Mm.
and she's reaching above her head now. She's
Right.
not. There's still a lot of work to be done, but we've she's come a long way, and it's been her hard work that's done it.
Yeah. Right. Well.
All right.
Yeah.
So again, the critical steps: stick to the timelines. We can't take any shortcuts. Therapists and patients want to jump ahead. We find if we jump ahead or we don't stay with these timelines, they will they'll crash.
Mm.
They'll lose the process. If you have a problem in any phase, you have to go back and redo the last phase. You stay there until you can move ahead without increasing pain. You have to be
Mm-hmm.
disciplined.
Mm-hmm.
All right. The patient has to have no sense that they're in danger. That when they do feel discomfort or pain when they're working, that it's not a dangerous situation. They can quickly tamp the symptoms of pain back down. We have to provide pain neutralizing strategies, breathing techniques, imagery techniques, relaxation techniques, anything at all we can do to help that patient control the breakthrough pain and the challenges that they experience. And then the treatment has to be fun, kind of exciting,
Mm-hmm.
make it relevant, make it interesting. We're going to do a lot of the same things over and over again, but you got to change it up and make it. But you got to stay within that narrow, focused area of not pushing them into a painful place. All right.
Okay.
And you have to foster independence, and that they are. It is their process. They own it. I'm only the guide on this journey.
Mm-hmm.
It's not my journey. It's their journey. And once they own that, they will more likely than not improve. All
Mm.
right.
Yeah.
And that's critical.
That's
All right.
powerful. Yeah.
All right.
Yeah.
And any other questions come in during that time?
Yeah,
I
a
can
couple
jump in.
questions regarding what you were just talking about. Leslie says, first, thank you for all that you did for me last summer. You mentioned vibration, and it is truly difficult for me, particularly driving or riding in a car. What process do you recommend for vibrations, if any? Thank you, Leslie.
Yeah, vibration is a challenge. So what we tend to do is we try to find a frequency or a very indirect way to bring vibration toward the body. Um, as I mentioned, this patient, we actually, for her left hand being injured, we had the vibrating clippers on the floor next to her foot to get it started.
Mm.
We had to find a way to introduce vibration into the system without creating a painful response. So if you're doing vibration therapies and it's creating pain, you need to find a way to get less direct. We had one of my patients that she couldn't tolerate, again, driving in the car, so we actually strapped a vibrator to the bottom of one of our waiting room chairs with padding around it to find a level of vibration she could tolerate, and we slowly removed the padding so that she could, and you could call that desensitization.
Okay.
But we're basically introducing a stimulus that the body sees as non-threatening, and hopefully in a way that they can start to process that stimulus without assigning meaning or pain to it.
Mm. And for your
All right.
case history that you did when you had her standing on the I forget what it was now, the thing to shape the dog, the clipper,
Mm-hmm.
did that
Mm-hmm.
work? I mean, was she able to hold the clipper again, or
We're
she's
to the
still
point
working on
now. She's actually working more closely with my hand therapist now at this point,
that?
because we've taken her to the point where we've got everything pretty well moving, and yeah, she's better able to tolerate the vibration. We don't have to wrap it up in a towel. I think
Mm-hmm.
arm is the involved side. She holds the clippers in her right hand, but it's still a little bit dicey, but
Mm-hmm.
than what we started with, and I'm optimistic that we haven't reached the end point. We're
Right,
still
right.
still working on it.
Yeah, well, she's made amazing progress. I mean, just truly amazing. Uh,
Yes. Here's the answer
Paula,
key.
okay,
You can keep asking questions, but I
okay,
know people might want to know if they did take the test, how they did.
okay.
So,
Paula, let me just ask you, there's two more. Paula asks, what
uh-huh.
is causing the modeling appearance in the arm? I know you
Well,
talked about that, because you explain that again, please.
I'll be a little technical, but I won't get into any big crazy terminology. So, the same neural pathways where nociception or the signal of pain, those nerves also act um, as glands that release chemicals into the tissue. And the chemicals that they release are the chemicals that would make you blush, make your palms sweat, um, make your skin look a little bit blotchy if you were embarrassed. Um, so those chemicals cause the small blood vessels to either constrict or to dilate. And when the tissue has been awash in those chemicals, the blood vessels lose their ability to actually change and become evenly regulated. So we look at patients that have these chronic pain or these nerve injuries, and we'll typically see the extremity where that injury is the skin being very mottled, very irregular or reticular or net-like in appearance. And that's a sign of neural instability. It's not a circulation problem all by itself. It's really a neural circulation
Hmm.
problem where the nerves going to the tissue that interact with the blood vessels change the way the blood vessels behave through chemical reaction and also through working the small, little tiny muscles that cause the blood vessels to dilate or constrict. Those become actually dysfunctional, and that's what you're seeing there.
Okay. Okay, and Josie asks, what would keep the patient with back pain from feeling pain while moving in front of a mirror?
Well, we're not going to turn their pain all the way off. What we're looking for is a way to lower their pain or discomfort enough that the movement that they're doing does not enhance the pain or discomfort. When you've injured your back, which most of us have, by the time you get to my age, you've probably done a lot of that. I've been a victim of that as well. You're almost afraid to move. And we found that if we can lower the fear factor to movement, we can lower the
Mm-hmm.
pain level considerably. Now, there's a lot of other skill that comes into play with these patients that are suffering from chronic back pain, but we've found that if they've gone through that acute phase and they're still having pain, the tissue's had plenty of time to actually recover from a tissue recovery standpoint, where you're still in pain. Now what happens is the movement itself becomes a painful process. So if I can, little by little, get you doing a little bit more, we call it a goal-oriented movement program, we find that those patients actually can regain a considerable amount of function, and they can do so without their pain increasing. In most cases, actually, their pain diminishes. And we find that, again, the mirror is helpful in keeping that pain level from getting out of hand. It's not like we put you in front of the mirror and your pain disappears. If I had a mirror like that in my clinic, I would be so busy, I wouldn't be able to keep up with it.
Right.
But if we can make it so that your exercise process is much more effective, much more enjoyable, less of a painful experience, then you're going to do a little bit more. And that's what we use the mirror for, is to just take those pain levels down just a little notch here or there. Right?
Yes. Okay. Thank you for that answer.
Mm-hmm.
Okay. So here's the question. Here's the answers to the questions.
Yep. So I think that's been enough time for you to write them down. I did list my references here as well, but they're much more than this, but these are the major references I use to build the information for this talk. And there's so much more. This is just really scratching the surface, but this is pretty much state of the art right now with dealing with chronic pain, is to take more of a top-down approach.
This Mosley graded motor imagery for pathologic pain back in 2006.
Yes.
So I thought that this graded motor imagery was fairly new, but it's been around a little while.
Yeah, if we Mosley is one of the major individuals, and if you happen to ever want to learn a lot more about pain, he has YouTube videos up. He's from Australia. Very, very entertaining individual. Absolutely brilliant. He's a physical therapist who's a specialist in neural pain sciences. In fact, he publishes more on pain science than almost anybody I know of. And he's a physical therapist. He's a brilliant, brilliant man.
Okay.
And he was just recently in Philadelphia for a pain conference.
Oh, really?
A 3-day pain conference.
I'll have to look him up. It's very interesting.
All right.
Yeah. So anything else, Mark? Or
nope. I know that people. I didn't leave any formal information as to how to get a hold of me, but I know that that's going to be available later on for everybody. Just be respectful of the fact that I am in the clinic with a busy caseload, but I'm here for anybody. I'm happy to help people, and I'll do my best to help you out, definitely, if you need some help. Okay,
great. We appreciate that. And Helen says, thank you for all you do with your patients. You give them hope. And that's beautiful.
Those are words that I live by.
Yes.
Right?
Yeah. So just to give Mark's contact information, he is at the Medford Nova Care. The number there is 609-953-7227. And for people that may be out of town, that's Medford, New Jersey, Nova Care, 609-953-7227. His email address, and it's okay, Mark, if people need to email you a question.
Email me a question.
Okay.
That'd be fine.
It's mbutler at H as in Helen, Q as in Queen, .novacare.com. And if anybody has any questions, didn't get that information, just know that it will be archived on our website, www.tdinj.com, in the next day or two, and we'll provide that link for you in addition to the YouTube link. Well, Mark, I can't thank you enough. I know how very, very busy you are, and I really just appreciate you taking the time to do this presentation, to bring some awareness around this. I think it's just so important, and bringing it all together in the way that you're doing, and the care that you show your patients. And thank you.
Thank you. It was a true pleasure. And good luck to everybody out there. Thank you again.
Thank you. So next month, on April 26th, we'll be presenting Kristen Wistar. She is a interior designer, a feng shui master, and an international speaker. Kristen is committed to educating and enriching people's lives by enhancing healthy energy and merging beautiful design into their environments. Her topic will be Sleep Your Way to Better Health and Well-Being with Feng Shui. That'll be on April 26th from 7 to 8 p.m., so tune in. As you know, your confidence in us is our highest compliment. If you find value in the services that TDI and Health Through Awareness provide, please consider leaving us a positive Google review. You just go to tdinj.com, click on the big G for Google, and that's up in the top right-hand corner. So thanks again, Mark. Thank you to all who joined us, and we wish you all a good night.
Good night.
Good night.